here, which I'm excited to make an announcement that we're going to change the name to the Whole Person Care Collaborative, which is very exciting. And that's our first public announcement of that here in this session. So thank you for joining us. And on behalf of the collaborative, it is my pleasure to introduce our distinguished guest, Dr. Megan Voss. Dr. Voss serves as the Director of Education and Associate Professor at the Bacchus Center for Spirituality and Healing at the University of Minnesota. Her commitment to advancing integrative health and healing is evident through both her academic leadership and her clinical expertise. Dr. Voss brings a unique blend of experience as a psychiatric mental health nurse practitioner and as an adjunct clinical associate professor in the School of Nursing. She holds a doctorate in nursing practice, specializing in integrative health and healing, and has advanced her practice with a postgraduate certificate in psychiatric mental health. Dr. Voss's research focuses on cancer and rare disease symptom management, improving quality of life and mental health in people diagnosed with rare and life-limiting diseases, especially Fanconi anemia, integrative health approaches for children and young adults living with cancer, and enhancing the well-being of patients and caregivers through holistic evidence-informed interventions. With her holistic approach, research expertise, and dedication to education, Dr. Voss is a recognized national leader in the fields of integrative health and mental wellness. And please join me in welcoming Dr. Megan Voss.
Well, thank you, Bethany. That was a very kind and generous introduction. I'm happy to be here today. I have a personal connection to Cincinnati, so I have family there and love your city and love visiting. So I was happy to receive the invitation and happy to be connected with Bethany and now all of you. We have a lot of content today, so I will try to strike a good balance between giving you some content and then saving time for some conversation and some questions. So just a quick check, Bethany, you're still seeing my slides okay and they're advancing and all seems good on your end? Okay. Very good. This is just a little picture of where I'm coming from. Today I'm coming to you from my home office, but we are located on the east bank of the Mississippi River. So that is a view of our campus. So Bethany did a great job of introducing kind of who I am. I wanted to say a few words about my journey because it's been maybe a little bit circuitous and to some it might seem like I've done a lot of different things, but they're actually all very connected. I started out with my DNP in integrative health and was prior to getting my DNP in integrative health, I've always worked in oncology and specifically hematopoietic stem cell transplant. Done a variety of inpatient and outpatient and really had a deep interest in palliative care and helping people just live better lives with more well-being when they were in the midst of a cancer diagnosis, which is what led me to the integrative health path of the DNP. And the more I got into that work, I found it very fulfilling. There's a lot of integrative health strategies that are very useful to people going through cancer treatment. But in my last integrative health role, I was working with adolescents and young adults who were going through stem cell transplant and finding that I was just at the edge of my role and scope a lot because there was so much mental health burden for these people with chronic illness. And I first started out thinking there's got to be somewhere I can refer them. They need mental health support. And then finding there weren't a lot of mental health practitioners who understood the disease burden of chronic and severe life-limiting illness, or the ones that existed were just overwhelmed. And I was in a really niche area with some rare diseases affecting very young people, and there just weren't people out there. So I pursued a postgraduate certificate to become a psych mental health nurse practitioner because I felt like I needed to be able to diagnose, and I had great interest in being able to de-prescribe actually, because a lot of these young people were started on pretty significant mental health medications when they're in the midst of an acute health crisis, and they're just sort of lost to follow-up in some very formative years that didn't quite sit well with me. So fast forward, now I have a clinical practice in psycho-oncology. I practice 2 days a week, and then Bethany mentioned some of my other academic and research work, and I'll talk today a bit about how those things all inform one another and kind of go together. So the objectives today, we will talk a bit about what is integrative nursing, how do we define it, what are the principles that guide it. We'll talk about the roles and responsibilities of all advanced practice nurses in providing integrative care to their patients, and review some national practice standards that apply here. And then I'm going to give some real world examples of how you can apply these strategies. That focus mostly on mental health, but I understand this is a mixed group, all kinds of advanced practice nurses. So hopefully some of my examples are broad enough that you can see yourself in at least one of them. And then I'd be amiss if we didn't talk about your own risk of burnout and your own mental health and all of this, and how integrative nursing can play a role there too. So I start by asking the question, why integrative nursing and why now? It's a tough time to be in the world. It's a tough time to be in healthcare. And I think it's important to put it into context. One thing I haven't said yet is that you all are getting a sneak preview of the new integrative nursing textbook. I don't know if you're familiar with the second edition of integrative nursing that's been out for about, I want to say, 6 years. And we just wrote a new edition in the last year, and that will be out this fall. And so a lot of the content you're getting today, I've pulled together because I've been able to read most of that textbook already. So you're getting brand new content that's not even in press yet. And so I'll reference some things that you might want to jot down and refer to when that book is out. So I'm going to start today as the third edition text starts out, which is by reminding us all of the core essence of nursing, all of nursing. I'm sure you all know Florence Nightingale said that the role of the nurse is to put the patient in the best possible condition so that nature can act and healing occur. As I've come to really try to interpret and apply those wise words in the 21st century, it just leads me to this very simple definition that integrative nursing is whole person care. It honors the person's mind, body, and spirit. It's healing centered, it's relationship based, and it forces us to view people as whole systems that are inseparable from their environments. And that is the broadest definition of environments, whether we're talking about the built environment, the natural environment, the family system that they're connected to, all of the different components that are impacting their health and well-being. And one thing I feel kind of pretty passionate about saying to any group of APRNs, and especially those of you who are in this very critical point of your training and about to launch into the world of becoming a provider, is that as advanced practice nurses, I want you to stay connected to your nursing roots. I think there's this real temptation when you become a provider to sort of succumb to the medical model. But we are nurses first, and we are trained in a different paradigm, and that really becomes our strength in practice. So even though you might be in a system someday or currently in your clinical rotation that is forcing you into that medical model, I encourage you to always be thinking of ways to go back to your training. Who have you been trained to be? How have you been trained to be with people? And how have your patient experiences up until this point shaped you? And how can you kind of harness that as a strength as a nurse practitioner? I think it's really important that we feel empowered to own our practice and the differences that make us so special in terms of the types of providers we are. So with that being said, we all know that a lot of nurses are working in large and complex systems. And while those systems do provide valuable structure and stability for our practice, we are not without challenges. In many systems, nurses are facing understaffing. Provider level APRN or advanced practice nurses are also facing that crunch of productivity and maybe not enough providers and too many patients. We work in hierarchies that sometimes prevent us from working at the top of our licensure and role and scope, and prevent us from utilizing all of our skills. We encounter all kinds of bureaucratic hurdles and disjointed models of care. And often I think nurses and nurse practitioners, we take on the biggest burden of care coordination. It's part of what makes us really good at our job. We become really expert at anticipating and navigating those challenges. And when we are constantly being the force that is carving out those tributaries so that patients can get their needs met, and we pride ourselves in doing that, frankly, doing that day after day, along with fulfilling that role of chief patient advocacy officer, it can leave us feeling kind of exhausted. And I think it's something worth paying attention to and continuously talking about. And as nurses and nurse practitioners, we encounter incredible amounts of secondary trauma, which our training has rarely prepared us for it, if at all. We may experience overwhelm by the sheer volume of work and patients and tasks and technology and updates and changes and challenges. And though we embody the essence of nursing, as I described a moment ago, we can drift slowly over time from the purpose of our work. We can begin to believe that what we were doing might not matter as much as we had hoped. We can start to feel like we're disengaged and we're just cogs in this large machine instead of beings whose life work is to really connect with and care for other beings. In summary, the system can injure us and leave us burnout with few resources and little validation, and in worst case scenarios, even gaslighting as to what it is we've experienced and the type of healing that we need to recover. So we'll come back to this idea towards the end. But I don't want us to stay in that place of dark space, that dark space and place of despair for long. The message today isn't you're doomed, you've chosen the wrong line of training. That's not what I'm here to say. I'm here to offer some, solutions, some suggestions, and things for you to think about on the front end of your practice as a nurse practitioner. So as I mentioned, a lot of what I'm going to go into next comes from the new 3rd edition of Integrative Nursing, which is titled Integrative Nursing, A Whole Health Perspective. So put a reminder to yourselves to look into that later this fall when it's published. So the definition that's offered in the 3rd edition is that integrative nursing is a way of being, knowing, and doing that advances a whole health perspective to optimize well-being. Integrative nurses use evidence-informed strategies to support whole person, system, and planetary healing. And there's 6 principles that go along with integrative nursing. These have been around for more than 10 years at this point, but we are continuously updating them and letting the evolution of practice inform them. So there are some slight amendments from previous versions you may be familiar with if you followed the integrative nursing movement. I'm not going to spend a lot of time on this slide right now because I've woven them into the examples that I give you later on in the presentation. So we'll come back to these, but just kind of take a note there of some of the key themes and the principles, including, those focused on patients and care delivery, and then also the 6th principle, which is focused on the well-being of the caregiver. Also in the 3rd edition, and a new sort of way of talking about using the principles that we've devised is these 6 core concepts. So we carry these through many of the chapters. Those are presence, mindfulness, compassion, intentionality, whole health, and well-being. And these 6 core concepts are described as a way to help integrative nurses embody the principles of integrative nursing and display the behaviors that are necessary for applying the principles in practice. So next I'm going to talk a little bit about role and scope, and then we'll dive into application. So I'm a psychiatric nurse practitioner, as you now know. So I'm focusing a little bit about how I conceptualize my role and scope as it overlaps with the Venn diagram of integrative nursing. Some of this will apply to some of you in the virtual room today, and others of you may have slight variations on it depending on your specialty area, your population focus, and even the state that you come from. I thought about focusing this a little more on Ohio, and then I realized you're probably all from different states, knowing that Bethany does not live in Ohio. So you'll have to maybe do a little homework to see what exists for you, and we'll talk about the national standards. So as a psychiatric nurse practitioner, we're all governed by the American Nurses Association scope and standards of practice, and we'll dive into that in just a moment. And then our state boards of nursing practice. One thing that's super important to remember, I think sometimes advanced practice nurses think that they lose their RN role and scope of practice, and actually you're just building upon it. So whatever exists in your State Practice Act for your RN scope of practice, it will still apply to your practice. And that can be useful in many instances in providing a greater level of detail or guidance to rely upon. And then there's the National Board Certification Credentialing Centers. There's a couple of them. ANCC is the most common. And so we'll talk about how that plays a role as well. So this is just a quick screenshot to show the Nurse Practice Act. This is Minnesota, as I snapshotted. You're all familiar with that. So that's the first thing to reference if you're thinking about what is my role and scope with use of integrative therapies? What do I need to know first reference your Nurse Practice Act. And then about 23 of the 50 states have a separate statement around the utilization of integrative therapies within nursing practice. The other states that don't have this, it doesn't mean that they're not allowing or accepting of the use. It just means they haven't really taken a very detailed stance. And in those instances, you can often rely on some of the national guidance that we'll talk about in just a moment. But here's a screenshot of Minnesota's, and we have probably one of the oldest and most detailed statements of accountability for the utilization of integrative therapies in nursing practice. So if you are part of an advocacy group in your state or wanting to get more language into your Nurse Practice Act, this will be a great resource to reference if you're looking at drafting one. So as I mentioned, there are national standards that we all abide to. So think of, national scope and standards as guidelines, and then of course, State Practice Act as laws. So kind of different levels of guidance that we have to follow. And of course, the legal edge of our scope of practice is the end all be all, but we look to national credentialing bodies for additional guidance and details around what we do as nurses and advanced practice nurses. This is an excerpt taken from an article that I published and I referenced later on in the presentation if you want to read the entire article. But this really describes how the ANA scope and standards of practice align with integrative nursing. We've published this actually in a couple of different places now, so very referenceable if you're looking at justifying an integrative practice. So the newest fourth edition of the Scope and Standards of Practice addresses the use of integrative therapies explicitly. It notes that advanced practice nurses and registered nurses should become competent in prescribing traditional and integrative evidence-based treatments and therapies that are compatible with the healthcare consumers' cultural preferences, norms, and abilities. So it's becoming more and more of not just a nice to have, but an expectation of our governing bodies that we are familiar with the evidence behind these integrative approaches. And then for those of you who are psychiatric mental health nurse practitioners, I think we have some of the strongest language to support the use of integrative therapies in our population-focused competencies. So this comes from the National Organization of Nurse Practitioner Faculties. They have a population-focused competency document. It's a little bit dated now, 2013, but it addresses all the different population-focused nurse practitioner specialties. And for us as psych mental health nurses, we are held accountable for having competence in helping patients use both pharmacological and non-pharmacological interventions, for understanding the evidence base of complementary and integrative approaches. And then you can see there's two competencies, number 11 and number 17, that really outline specifically what we should know and how we should guide the patient in those use of therapies. So I think it's just interesting to know, because a lot of times people get a little nervous about, can I do this as part of my nursing role and scope? What should I be doing? One of the things I didn't highlight before on the Statement of Accountability for Minnesota's Practice Act is that there's language in there that just says you should be educating yourself from reputable sources about the types of integrative therapies that you're using. And it's pretty vague guidance, but things like this, continuing education, of course, any academic courses that you take, journal articles that you're reading, all of those will be considered reputable sources for training yourself. And then there's, of course, different levels of competence, right? There's understanding enough to make a referral versus understanding enough to actually apply the therapy yourself. And depending on your practice setting and your role, your focus, your capacity, you get to determine kind of the depth and breadth of what you want to spend your time becoming competent in. So next I'd like to move into a few practice areas to give some kind of thoughts and examples on how I think this applies in the real world. So I'm going to start off with community, because I think for those of us who are in mental health, we're very tied to community. But everyone who's working in ambulatory care needs to be paying attention to community well-being and how their patients are living and being in the community. And I think it applies to a lot of you. So it's also taken from some great chapters in the third edition that I think nurse practitioners will really love. This chapter on community well-being, Dr. Gaskins, Johanna Gaskins, is a graduate of the University of Minnesota's program, And she owns a really unique nurse-led business. It's doing some pretty cool things in terms of a nursing or nurse practitioner focused practice and integrating well-being and a deeper integrative approach to care. And she's out there on the web. She's easy to find. She's published in the book. So she'd be someone to pay attention to if you're looking, who are the nurse practitioners in this space? Who's charting the pathway? She'd be a person I'd put on that list. And in the chapter that she co-authored, they write, well-being is not just the absence of illness, but also the presence of positive factors, including life satisfaction, purpose, and resilience. And I think that's such an important thing to pay attention to, no matter what area of healthcare you're working in. And it brings me to the well-being model. This is the model that we developed at the University of Minnesota. And I think it so well illustrates that health is just 1/6 of the total piece of a person's well-being. The other 5 areas here, relationships, sense of safety and security, sense of purpose, community, and the environment, all play an equal role in how well a person feels. And I can say, as someone who's worked in a lot of acute care settings, chronic cancer diagnoses and rare diseases, it's so true. I've seen patients whose physical health is terrible, but they have a high degree of well-being. And then you see patients who, are cured, or their physical health is better than ever, and their well-being is at an all-time low. And it's because of deficits in the other area. And I'm sure all of you already have enough experience in healthcare and nursing to know that that's true. And you can probably think of your own examples of that. I also like to reference the World Health Organization's definition of well-being, which states that well-being is a positive state experienced by individuals and societies. Similar to health, it is a resource for daily life and is determined by social, economic, and environmental conditions. Well-being encompasses quality of life and the ability of people and societies to contribute to the world with a sense of meaning and purpose. Focusing on well-being supports the tracking of the equitable distribution of resources, overall thriving and sustainability. And I think one of the things I'm particularly struck by in this definition is it goes on to say, a society's well-being can be determined by the extent to which it is resilient, builds capacity for action, and is prepared to transcend challenges. I think that's so true at the level of the individual, at the level of the community. And I also think about it as it applies to our entire profession. How well prepared is nursing to be resilient, to build its capacity for action, and to transcend the challenges of the next generations? I think it's a really important question we have to be asking ourselves right now with the rise of AI, and wondering what it is that we as human beings in these professions bring to the profession that can't be replaced by technology or AI. And I think some of that is that human touch, that connection, that relationship. I mentioned that I would dive a little deeper into the principles in these upcoming examples. So the first principle we'll kind of talk about is that human beings are whole systems, inseparable from and influenced by their environments. I think that's so well seen in community nursing. So from another chapter in the new textbook on community nursing, they outline challenges that are faced by society or people in communities today. And those are social isolation, mental health deterioration, and then a general yearning for community connection and a sense of belonging. And strategies that integrative nurses can use in the community to connect individuals to place, purpose, meaning, value, sense of belonging, and that feeling that one's life matters. I think so often as nurses and nurse practitioners, taking the time to talk with people about some of these items can be more impactful than any medication that we can prescribe. Effective community nursing helps connect people to these things that they're needing most to meet those challenges we mentioned on the previous slide. Human beings are whole systems, inseparable from and influenced by their environments. And so we can apply that principle to help connect people to their own well-being and capitalize on their strengths. The next principle, number 2, human beings have an innate capacity for health and well-being. I'll use a few excerpts from the chapter on palliative care to highlight this principle. Whoops, got a little rogue there. Palliative care is not an area I currently practice in, but it is an area that I've tracked throughout my career because I think we can learn a lot from nurses and other providers in palliative care. They do a lot of things really well. They're really person-centered in palliative care, and the chapter on palliative care is written by nurses from a couple of different institutions, but one of them is from Mayo Clinic, and she's done an incredible job of leading a very whole person palliative care effort for whole person care at Mayo Clinic. And she writes, palliative care and hospice nurses are well positioned to create and hold space for core trauma-informed care practices, such as acknowledging and validating emotions, reframing, listening deeply, therapeutic sharing, practicing non-judgment, creating psychologically safe space for patients to feel respected, building trust and rapport, and using silence as a healing strategy. So while she's talking about hospice and palliative care, I think there's something that each of us, no matter our specialty, can take from these words and from this list, because it really is seeing our patients as whole people and capitalizing on that relationship to meet them where they're at and to really hear what are their needs. You know, so often what a patient is referred for, what they come to see you for, is not, you know, what it appears on the surface is not actually what they need. And so it's part of our job to do that deeper connection and assessment work to figure out how we can really help them heal. And now I'll transition to into mental health, which, as you know, is my area. And so I have some more robust exemplars and deeper ways of talking about the application here. So I told you a bit about my career trajectory, that I started in oncology, hematology, and BMT. I transitioned into integrative health and worked in pediatrics and with young adults. And then I became really connected to a rare disease group, the Fanconi anemia community. And that's important because I'm going to use some exemplars from that group. And they're a really unique group to work with because Fanconi anemia has a couple of things. That it's a bone marrow failure disorder, so they have a stem cell transplant to help with that part of the disorder. It's also a DNA repair disorder, and people with Fanconi anemia have a risk of certain types of cancers. It's about 700 times the risk of the average person. And so this is a group that experiences a lot of serial medical trauma, and there's not a lot known about them. And so it's been a really interesting case study for me to get to know this patient population, to understand their needs better, and then to highlight principle number 3, which is that integrative nursing is person-centered and relationship-based. And I think it's easy to lose track of what that means, to center the person and their relationship. But when you work with a rare disease where very little is known about the disease, and working with the first generation of people to live into adulthood with the disease, you're figuring it out as you go. And it forces you to center the person and the relationship, to understand the needs as you're developing strategies for working with this group. So I'll dive a little deeper into what that means to be person-centered and relationship-based in this area for me. So my practice, my research are both in this area. And as I mentioned, it's a rare genetic disorder. The risk of cancer is high. And because they have this DNA repair, their DNA repair pathways do not function typically, the typical cancer treatments don't work well for them. So things like chemotherapy and radiation are particularly risky and damaging to their tissues. And so for that reason, frequent surveillance and surgical excision are the mainstays in cancer prevention and treatment. So you can imagine when you're teaching a group of people to constantly be assessing their areas of risk for signs of cancer, and then constantly doing surgical intervention to remove precancerous cells, that's you're breeding a pretty significant set of trauma symptoms. You're asking them to be hypervigilant, and then you're repeatedly inflicting trauma on them. and they're living in this state of uncertainty and fear of cancer diagnosis. And yet there was very little known about the impact that this had on the community's mental health and quality of life, because it's only been recently that these people have been living into adulthood. So until recently, there were no studies published that told us about the mental health and the issues of quality of life that this group faced. And in late 2020, I was approached by the Fanconi Cancer Foundation to see if I would partner with another quality of life researcher to start to better understand the needs of this community. So this was in 2020 when the world was in chaos and we didn't really know where to start. So little was known. There was no lit review to do. And so we just started by holding listening sessions. It was the early days of Zoom and the height of the pandemic. And we just asked people to come, and we sat and we listened and we took a lot of notes. And in the past 5 years, we've just kept listening to the community to sort of build this research program and a practice around it. So we published the first large-scale study of mental health in the first generation of adults with Fanconi anemia. And we learned a lot about the well-being of these people. And part of how we learned it was by listening to them and centering them even in the research design. We used a patient advocacy board who helped us design the study. We would listen, we would come up with a design, we would come back to them, we would test it out on them, and they would say, nope, you got this wrong, or yes, you got that right, and we would redesign the study, and we would come back to them. And we just did this iterative process until they said, yes, you're asking the right questions in a meaningful way that's not too burdensome to us, and then we'd move forward with it. And then when we got results, we'd do the same kind of iterative process again of checking with them. And that was the way that we built the relationship, we built the trust with this community, and we made, I think, a really big impact on the disease by centering these people and understanding deeply what their needs were. They gave context, and because we centered the voices of the individuals in the community and they co-created the study with us, we were able to feel really confident that we asked the right questions and designed a study that had the most potential for impact. So you may feel like I'm getting down into a rabbit hole or a tangent, and maybe I am because this is a passion area of mine. But what I wanted to highlight here is that these principles of integrative nursing, they don't just apply to your work in the clinic. As DNPs, I hope many of you go on to either be involved in research or quality improvement, or just leadership and systems in general work to improve the patient experience, and that you can remember that these principles can help guide that work too, not just the work you do with patients. And so the last thing I'll mention, to not get too far down this rabbit hole, is that I think the Fanconi Cancer Foundation has now come a long way from our early Zoom meetings. They now have a formal patient advocacy program where they train people with FA and their family caregivers to be advocates and to partner with all researchers in this rare disease group, which is such a cool and important way to approach a unique rare disease. So all that is to say that I have this kind of cool situation where I have the patient experiences that inform my research, and then my research informs my practice, and then my practice informs my research, and it's kind of this great sort of infinity loop where I get to really form those relationships and have that impact my practice. And you all might not have the exact same thing, but I hope you look for opportunities to do something similar. So with that, I'll transition a little more into what does my practice look like and how do I bring integrative mental health to life. I would say on paper, my practice looks pretty standard. I do psychiatric medication management. I do supportive psychotherapy. Bethany and I were just chatting about that before others were on. As psychiatric nurse practitioners, that's part of our role and scope, but a lot of people choose not to do it. And it's hard to imagine not doing that as part of my practice. I do a lot of care coordination, and sometimes I'm just doing some consultation for patients on a shorter term basis. But generally I have longevity with my patients. So diving in a little more deeper to some detail about my practice, I am allowed 90-minute intakes and 60-minute follow-ups at my practice if I need. I can also do shorter. I don't have to keep them that long, but having that gift of time with patients allows you to really apply these principles. So these are things to think about when you're considering where to work after graduation. what kind of autonomy do you have over your schedule? How many patients you need to see, the length of patients, the way you're billing, the codes that you're able to bill for. These are important things to think about if you want to have some autonomy over the way you practice. Because while I believe that any person in any setting can apply some principles of integrative nursing, it is admittedly harder to be person-centered and relationship-based if you're seeing a new person every 15 minutes, or you're never seeing the same person twice. That can certainly present some more challenges. Other key components of my practice, I generally ensure that the patient is setting the agenda, that we're covering what's important to them. The decisions we make are made together in partnership with the patients. I have that longevity and continuity of care, which is becoming more and more rare in mental health as these kind of consultative and integrated mental health care practices pop up, where a psychiatric nurse practitioner might be partnering with a primary care team or many primary care teams, and you're really providing one-off consultative support or time-limited support. Those would be challenging, I think, to have as much of an integrative impact, though you can certainly do it. Things to pay attention to when you're deciding how to craft your practice. And then in terms of whole person care, I'm constantly employing deep listening, broad assessment strategies, and what I've recently started calling creative care planning, and I'll tell you a little bit more about that in a minute. So deep listening, what does that mean? It means sometimes changing the questions we're asking people. Just the other day, I had a patient who came to an appointment needing to discuss transitioning her care to hospice, and she appeared really anxious and rushed. And so I took an intentionally slow pace with her and asked several deep follow-up questions. And she was so taken aback, she stopped and she looked at me and she said, "I'm sorry, I've never had a psychiatric provider take so much time to talk to me." And this was 13 minutes into our appointment. And it was a real moment of realizing what people become used to in the system. So my point there is just that I think sometimes patients need us to ask the right questions to give them permission to share more, because they are becoming as jaded by the systems as we are, by feeling like they always have to be quickly getting through their appointments as well if their providers are always rushed. I also take a deeper assessment approach to assessing lifestyle, a patient support system, what their goals are, and even asking how people's experiences with their care teams are going. And I work with pretty medically complex people, so they're interfacing with a lot of teams and have a lot of medical trauma, so that can bring up some really important conversations for us, maybe less applicable for some people. And then creative care planning. This means using therapeutic presence. It means tapping into a patient's creative outlets that they already have, their supports with their family and community, lifestyle factors, using mind-body techniques, and then using both self-directed integrative interventions and then referral out for other integrative interventions. I will say that I think when people are new to learning about integrative health, there's something that's kind of really enticing about fancier integrative therapies that are more expensive or require a referral. And I think the more I've practiced, maybe the more grounded I've become, where I'm far more likely to tap into someone's kind of niche creative outlet and build on that and come up with something they can do at home that's completely accessible to them, that brings them joy every single day, that is lasting, that they can build upon, than I am to refer them for something like acupuncture. Not that acupuncture isn't useful and there isn't a time and a place for it, but I'm just really realistic about what can patients afford. What's the appointment burden on them? Some of my patients just have far too many appointments, and going to another appointment in and of itself is not therapeutic. So just being really realistic about what patients need and helping to simplify it for them and reduce the pressure on them. So I'm going to take all of that and kind of go through a pretty simple case study here. And part of this case study will highlight principle 4, which is that nature has healing and restorative properties that contribute to health and well-being. So a typical patient for me is a man I'll call Don. He's 67 years old and he has a diagnosis of glioblastoma, so read shortened life expectancy. His anxiety is very high, his mood is very low, and he's got some impaired cognition. He has a supportive wife and daughter, and while they're a great family unit and there's a lot of support, there's also more and more interpersonal challenges emerging as his communication and cognition are struggling. And he has an abundant circle of friends and family. He lives in a small town. Community has been very important to him for a long time. So from those deeper conversations and assessments with him, I have learned that prior to diagnosis, he was very outgoing, very engaged in community. He loves art, and I should have on here loves nature. That's another big part of his story. And he's tightly connected to his family, even though there are challenges in the family system. Some of the challenges that he's personally facing right now are this disease-induced cognitive impairment, including aphasia. He's very easily overwhelmed and frustrated, and part of that is an organic brain process, and then it's kind of unfortunately a positive feedback loop. He's struggling with the loss of independence and change in his communication abilities, and he has some reemergence of childhood trauma and then an associated uptick in trauma-related symptoms. So what does creative care planning look like for a guy like Don? The standard things that you would do here, of course, we're going to optimize the SSRI dose. He was using a lot of medical marijuana. It says medical marijuana here. He was also just using a lot of marijuana, I think, prior to it being a medical marijuana situation, which of course is never helpful in the setting of impaired cognition and fall risk. And then together with palliative care, there's also been a trial of a low dose stimulant to help with cognition that we've been working on. So these are all standard things that if, you get someone that's this medically complex, and the amount of adjustments that you can make to medications are minimal within the safe range. And often I think the return on those is kind of low. But the integrative approaches have a lot of power for high return on investment. So the things that I've done with him at each appointment: simple breathing, grounding, centering, inclusion of family in his sessions. That helps with his communication, helps him to feel secure when his wife can step in and help him communicate. We work on strategies for being without doing, or being without needing verbal communication. So we've been working a lot on how can your community support you without coming and talking and having a lot of overwhelming conversation that makes them feel frustrated and left out. How can you talk with your friends and family about showing up and maybe just sitting with you to make you feel connected instead of talking at you, which makes you feel frustrated. We talked about increasing daily time in nature, and then sketching as he's sitting in nature, because that's something he'd always done, and it's a form of expression that's still accessible to him, and in a way that he can process some of the trauma that's coming up for him. And then connecting him and his family with family therapy, with a focus on grief, because that's really a lot of what's at the root of Don's struggle. So that's kind of a typical case study for me, which is probably not typical for a lot of you. So I'm going to go through a second case study, which is maybe a little more typical for a mental health nurse practitioner. This is also a real case I've worked with in my practice when I first started and had some more general patients. And what I want to highlight in this case study is that integrative nursing is informed by evidence and uses the full range of conventional and integrative approaches. We try to employ the least invasive or intensive when possible, and move to more intensive as needed, but recognizing that's not always possible. So I'll go through this one relatively quickly so we can save some time for Q&A. Sam is a 37-year-old who was referred to me by primary care for management of ADHD. He has comorbid cardiomyopathy and was directed by their cardiologist to avoid stimulant medication due to cardiac risk. He came to me on bupropion, 150 milligrams. He'd already tried atomoxetine, which was stopped because he had sexual side effects on that. As you can see here, symptom burden is pretty high. ADHD is impacting him in multiple areas of his life, impacting his relationships, his work, and his ability to parent. And he has quite a list of ADHD symptoms that are not well controlled. So how could we build kind of an integrative plan? First thing I think about are lifestyle modifications. So lifestyle, we look at movement, nutrition, sleep, and then substance use, reduction of risky behaviors. We could employ mind-body skills. There's a lot of evidence to support things like mindfulness, coaching with ADHD patients, CBT, and again, making sure you're using practitioners that know how to work with this type of patient. Not all coaching and therapy are created equally, and there are people who are very skilled at working with ADHD. So even just making those right connections and referrals is really important. There's quite a few evidence-based supplements in this area. We don't always have great, robust literature in the adult populations, more in peds. And so sometimes we're extrapolating a bit to see what's possible. There's some evidence for things like omega-3s, a daily multivitamin, and then other specific nutrients. But I use supplements sparingly and recommend where you can to draw lab values and base your dosing based on blood levels and only supplement judiciously based on the individual's need. But then there are some herbs that have decent evidence for ADHD. In this particular case study, I would omit those because of his cardiomyopathy and because many of the herbs that act like stimulants have similar risks. You have to be really thinking through that and making sure you're following the evidence and the risk profile, and again, extrapolating where the evidence might not exist to just avoid risk. So for this particular person, his bupropion was making his anxiety and his insomnia worse. So the first thing was to deprescribe the unhelpful medication, to work on improving sleep, because oh my goodness, if there's one thing I can send you away with today, people who are struggling with ADHD symptoms, work on their sleep, work on their sleep, work on their sleep. Because everyone thinks better, everyone's brains work better when they have a proper amount of sleep. I can't tell you how many ADHD patients I treated who are getting 4 to 5 hours of sleep regularly and wanting stimulants to fix things, and they just won't. They will burn people out. So working on sleep. And then nutrition, that's another big thing I find with ADHD adults. And then exercise, and if it can be done in nature, even better. And then referrals. We talked about ADHD, CBT, and coaching specifically. You can draw labs and check for nutrient deficiencies if that doesn't feel overwhelming to the patient. These say future considerations because we're taking a step-by-step approach and not tackling this all in the first appointment. And then supplements if we need it based on the lab results. And then accommodations. That's another thing that I think is really overlooked, but a part of whole person care is looking at what modifications to your life and routine can be made to support you, because sometimes it may not be a failure of your brain. It may be a failure of your work environment, a toxic culture you're exposed to, being asked to do too much, being asked to work in a way that doesn't work with your brain. And so having those conversations and getting creative with people about how you can help in those maybe less traditional or less thought of ways. And so here I just put it into a bit of a schematic that can help you think about how we categorize these interventions that are available to us. And I think of things like the lifestyle, behavioral lifestyle interventions, and then deprescribing as the basis, right? That's just like building blocks of well-being. And then we move up into the more focused, skills-based modalities. And then we save things like supplements and herbs and medication retrials once we have come to a better understanding of a situation and also worked on some of those building blocks. And then I just have to, in this instance, really highlight the importance of partnering with other disciplines. And I think health coaching is a really fabulous discipline that pairs really well with mental health. We have a new pilot starting where we're going to train our health coaching students to work alongside our medical residents in the ADHD clinic to see how can we really embed health coaching in the clinic. And I think it'll be a really cool pilot where we have another member of the team that can focus on these lifestyle interventions. Okay, so to summarize, whole person care, I hope that those case studies showed you that it needs to be individualized, evidence-based, approachable. I could add more words to that bullet point: approachable, realistic, accessible, affordable, all of the things that matter to patients actually following through, right? And then work with other professions, work together in a coordinated effort in a team. There's a lot of literature coming out about the shared mental model. So if you don't know what that is, look it up and find a work environment that will support you to have a shared mental model, because it is the most, I think, in my opinion, and some of the evidence is showing, it's one of the best things that can protect us from burnout. I have a few quick slides on leadership. Bethany, is it okay if we go 5 minutes over since we started 5 minutes late?
Yes, let's do it.
Okay, great. So just a couple of words, if you're working with leadership, if you're in leadership and you're wondering about the strategy of integrative nursing, I think there's some really great things in the new textbook, and I'll let you read that. But essentially the message I want to give you is that integrative nursing aligns with the bottom line. It helps teams connect to their why, their sense of purpose, and it helps systems to work more effectively and meet a lot of their goals. So there's a lot of good business sense to applying an integrative nursing approach. And then I have some slides on care team well-being, because integrative nursing focuses on the health and well-being of caregivers as well as those they serve. I wanted to ask you to take a few moments to sort of connect to your why. Why did you go into nursing? And what did you feel in those early days when you were gaining confidence and felt like you were in your right profession? I think it's important to go back to that. We won't take the time to do the exercise now, but I'll share my slides and you'll have the exercise in the speaker notes, and I hope you'll take the time to do it. And then I'm going to mention a book here that I think has been one of the most impactful things for me in terms of burnout. There is a book called Trauma Stewardship. It's a little bit old. 2009 is the publication date, but it's one of the best books, I think, that helps us to really learn how to take inventory of our own trauma exposures and responses. And you may be sitting there thinking, I haven't had trauma in my nursing career, and that probably means that you just haven't taken inventory of your trauma responses yet, because I think we all have had some. You may be managing really well. You may not be experiencing it right now, but I think it's important to learn how to pay attention and take personal inventory. So these are some questions from that book. You can get the book, or you can look at my slides and you can journal on some of these questions and pay attention to it and track over time. The book talks about self-care strategies in a way that I really like how she frames them. Her 4 categories of self-care strategies are some of my favorite. A sense of personal control, pursuit of personally meaningful tasks, healthy lifestyle choices, and social support. So I want to kind of wrap up by saying that my call to action to all of you with the use of integrative nursing is that it can be used as a tool to revitalize your practice, or for those of you that are at this very exciting point of launching into a new type of nursing practice, you can use this framework to design the practice you want. Use it to think about what type of environment you want to work in, what type of autonomy is important to you in your future practice. Use it to frame the questions that you'll ask the people interviewing you when you go to sit for those job interviews, because a big part of our well-being is the culture we work in. And integrative nursing can be a means of self-preservation. It can help you revitalize your practice by connecting you to your why, as we just talked about, enhancing those feelings of mattering and that sense of purpose. And it creates pathways for us to provide quality care, which is also ultimately very protective of burnout. Integrative nursing may be a motivator for practicing differently or leaving a toxic work environment. It encourages self-exploration and care of self and prioritizing a healthy lifestyle, and ultimately can help you restore joy in your practice. And then I mentioned the importance of community in self-care. It has been said that the most powerful form of self-care is actually community care. So I just want to encourage you all to find your community. And that may be your local community, it may be your church community, it may be a work community, it may be some obscure hobby that you find a community around, or in some ways it may be a professional community and connecting with like-minded people. So I want to invite you all to tap into the integrative nursing community that does exist. I know you have your own there that's led by Bethany, and that's wonderful. And I hope your community will connect to the national community. We have a Facebook presence, the Integrative Nursing Group. We also have some opportunities for obtaining more training in integrative therapies and healing practices at the Bakken Center. So reach out if you'd like more information on those. And we do a free integrative nursing webinar. It's about quarterly. And so the next one coming up is next month, and it's going to be a really great presentation called From Mat to Mind, Yoga's Integration into Nursing Practice, that'll cover both approaches you can use with your patients as well as things you can do for yourself. So wanted to put that out there. This is the article that I mentioned earlier that talks a lot about weaving integrative nursing into a psychiatric mental health nurse practitioner practice, but it's also co-authored with 2 adult gerontological nurse practitioners. And so the case study that we talk about in this article is actually not from a mental health practice. It's more how do you apply these strategies in primary care, because we know that all of you doing primary care and other specialties are also doing mental health care. So take a look at that article if you want a little more depth than what we covered here today. There's a really in-depth case study in that article. Because you're all University of Cincinnati, you're all eligible to join the Academic Consortium for Integrative Medicine and Health, where there are special interest groups on integrative nursing and mental health and many, many other things. These are your people. You can connect online, offline, in person. Lots of great webinars here. Also just a great forum if you're working on a project and you're like, hey, does anyone have a policy on X, Y, and Z? It's a great place to network across the nation with people doing really solid work. We will have another integrative nursing symposium coming up. This is the flyer from the 2022 symposium, because we don't have a new flyer yet. We're in the early planning stages. So this is an early announcement, but do stay tuned for more details. I don't think this website actually works yet, but it will be back up and running, and we will get the word out when the planning details are more or further along. And then finally, last thing, and then I'll pause for questions. Taking Charge of Your Health and Wellbeing is our consumer-facing website. So this has reputable resources, videos, practices related to integrative therapies and integrative health that you can send your patients to. So they can start by doing their own well-being assessment. You see that enhance your well-being, assess your well-being is the green button there that you probably can't see, and set a goal. So this is a great way if you have very limited time in your practice, but patients are interested. Website is meant to be patient-facing. They can assess their own well-being, they can set their own goal, and then they can find a lot of different resources to help them start practicing something right away. So it's a great resource for practice. And then I just have my references here and my email. So you're all welcome to reach out to me if you have questions or want to connect. Whew, I'm sorry that I ran over and talked so fast, but it was had a lot to share. So I'm going to take my slides down if I can, and maybe I can be able to see all of you for questions if anyone's still here.
We are, Megan. That was wonderful. Thank you so much for being with us. I followed integrative nursing for a while now, but revisiting it with an expert like you is always so wonderful, and to see that your case studies, it really brings it to life. So I'd love to open up this time for any questions that anyone in the audience has. The chat is clear right now of any questions, but feel free to open your mic and ask away.
Hi, Megan. I'm Amy Fathman. I am clinical faculty at University of Cincinnati, and I'm a family nurse practitioner. My question for you is the practicality. You mentioned, of course, we have this managed care system where the limits of this when we're trying to apply this in our practice, and how do you navigate, or how does your organization justify? Is there supplemental, is there funding that comes from other sources beyond what is billed for the 90-minute visit? Is that typical of the mental health consultation visit and our follow-up? So, and I guess, is the counseling combined with that visit?
Yeah.
I guess.
Great questions. There's no additional funding. I do think that in mental health, we have a little bit of a extra leeway in terms of how we can schedule, and we do bill add-on psychotherapy codes that help account for those longer visits and extra time. I also work in the teaching clinic, so we have all kinds of learners, and that's part of why our templates are able to be the way that they are, and we have a little more time than some of the other areas like primary care. But when people ask about practicality and are doing a busy primary care practice, I say this with the caveat of I've never done that. I have deep respect for people that are seeing a new patient every 20 minutes. But the best advice that I've come to think about is, what are the patients that you're working with most frequently? What are the common concerns you see, and what are the biggest bangs for your buck in terms of both the evidence and your investment in time? And can you have some resources that you can hand the patient that are ready to go? I think so much of what enhances well-being and where integrative care really shines is actually in the community. So sometimes it's as simple as asking one additional question and then having great community resources that you can send people to. Because it's true, you're not going to be able to counsel them and meet all of their needs and teach them mindfulness and manage their anxiety with an integrative approach in a primary care visit. That's just not realistic. At the Bakken Center, we have a whole array of community-facing webinars, and we've really worked to remove barriers. So they are available. Most of them are already free, but the ones we charge for, they're always available at no cost to people who can't afford to pay. So we have a wonderful series. We have a yoga therapist who does a series for things like, it's a multi-part series, but they cover low back pain, they cover anxiety and insomnia, and maybe headache, shoulder, neck pain. I can't remember the third one, but that's a great example of like a referral I'm sending my patients to often. And then they just need to follow the link in their after visit summary. And I'm often going in and creating dot phrases. So their after visit summary is just populating with some of these common things that I'd like them to follow up and check out.
One more comment. I actually learned of, and I don't know if you're familiar with this, but you know, nutrition is so important, and I find that with patients, but not a lot of time obviously in an appointment to get into details about that. And I always struggled to find good referrals for dietitian and dietary consultation. And there is a service. Have you heard of Nourish? Nourish. The website is usenourish.com. But it's actually pretty awesome. And 94% of patients will have insurance will cover the visit. And they are registered dietitians from all over the country. They do evenings, weekends, it's all online. But the cool thing is it's very individualized. So when patients put their intake in, they'll, if they have maybe an underlying autoimmune condition, or maybe, one of the rare conditions you mentioned, dietitians actually have sort of subspecialties too. And they, they tap in. And so you get a dietitian that's really tailored individually to you. And it's almost like it's covered almost like physical therapy. You get so many per year, so many visits. So I have found that to be so beneficial. And I actually get an intake. I get their notes, like their encounter notes every time. And I can kind of look at that and see what they're working on just to make sure that it's going. So for anyone who needs that might be just one aspect of it, because it's so multidisciplinary. I mean, we need to work together and collaborate with our colleagues. So anyway, that was just a suggestion I had. Sorry to take so much time for that one.
No, that sounds like an incredible resource. And thank you, Bethany, for putting it in the chat. I added our community well-being programming to the chat. We also have nutrition workshops. So if people need follow-up from a dietitian consult or more on that, we even have a duo that's an MD and a chef duo, and so they actually do food skills. So they take it a little step further and show people how to do it in their own kitchens. It's pretty cool stuff. So sounds like we should have a place to collect and share all of our resources. Thank you for the question, Amy.
Yes, I was going to say maybe even like a community resource mapping exercise, right? Where we bring together these resources in some sort of like collective place. I don't know. It just kind of came to mind. But I want to be mindful of the time that we've taken already, Megan, and you've been so gracious. But I would like to ask one last question kind of in closing. And that's, what do you think is the future of integrative nursing? And you feel free to frame that in, a whole person health perspective, or just generally. I'd love to see what you believe the future holds for integrative nursing.
Such a great question. It might sound a little cliche or a little cheesy, but sometimes we say we will know we have achieved our goal when we can drop the qualifier of integrative nursing and we just get back to our roots, and nursing just remembers what makes it so special. And I think that is even truer of advanced practice nurses who are more stuck in the medical model and have to remember how to get back to their roots. So I think that's part of my answer. And I think the second part of my answer is not just surviving, but thriving as technology takes over and people struggle more and more with isolation. And that as nurses, we have this unique skill set to be able to partner with people, to hear people, and to sit with people's pain and connect them to resources that can make them feel whole again and make them feel resilient in these especially challenging times in our society. So the future may be taking us backwards in terms of getting back to our roots.
Well, I love this. This has been so delightful. Megan, thank you for being with us, bringing your expertise. Thank you for all of those who attended live today. And for those of you who are watching this recording, we're grateful to have you in our community. And we welcome you to reach out to us with any follow-up questions that you may have. And we look forward to seeing you next time. Stay connected with us. We have some wonderful guest speakers that will be joining us in the coming months. But I'll tell you what, it's going to be really hard to beat this one with Dr. Voss. So thank you for your time. We're so grateful for you and all the work that you do.
It's been fun to be here. Thank you for having me.
Thank you.
Bye, friends. Till next time. Thanks.